Another gorgeous summer day in the great Pacific Northwest, and I'm sitting on the front porch talking about pus. Such is my life. This is the Puscast. This is going to cover the first 2 weeks of August 2014, and as always is brought to you by Pusware LLC. Go to edgydoc.com to find links to my growing multimedia empire, and of course, if you're bored, wander on over to iTunes and write me glowing reviews. Otherwise, you're interested in the literature, aren't you? So let's get started. I will wager that no one wants a brain biopsy, so it'd be nice to have an alternative way to diagnose Creutzfeldt-Jakob disease. When I was a resident, it was called Jakob-Creutzfeldt disease, and I don't know when the name change occurred, or why for that matter, but somehow Jakob got demoted. Maybe he got prion disease. In the New England Journal this month, there were 2 reports on diagnosing the disease, one with a nasal swab and one with a urine specimen. One used what they called the protein misfolding cyclic amplification technique, although the one for the nose used a much cooler sounding technique called the real-time quaking-induced conversion. I think the final is a much cooler sounding test. Basically, they get a small amount of prion protein, either from a nasal swab or a urine, put it in with regular proteins, and measure the conversion of the regular protein to the prion protein by a variety of techniques. And both are quite good tests diagnosing the majority of patients with Creutzfeldt-Jakob disease. So you don't need to do a brain biopsy now. Of course, I don't know if either of these are available clinically, but I'm sure they will be in the not-too-distant future. A wee bit on the epidemiology of Epstein-Barr virus. This study out of Minnesota checked serologies on 876 children for EBV between the ages of 18 months and 20 years of age, and found that non-Hispanic blacks tended to convert before adolescence, whereas Caucasians tended to convert in their adolescent years. So there's a marked difference in when different groups develop their Epstein-Barr infection. Why that is, they could not ascertain from this study. I was unaware, for example, that acute mono is uncommon in college-aged blacks and military recruits who are black, and this would explain why, as acquisition of EBV tends to be at a younger age. The best they could speculate that it was both genetics and family environment that contributed to EBV infection, and it also would impact a vaccine in that you would have to give it to black populations at a younger age to prevent EBV than the average Caucasian population. Summertime is time to sit outside, drink iced tea, play golf, and get enteroviral meningitis. Summer-fall is enteroviral season, and you should be seeing lots of aseptic meningitis in your community. Usually you get a spinal tap back and it just says enterovirus positive by PCR, but there's a hodgepodge of enteroviruses that can cause aseptic meningitis. This study looked at the viral loads and types of enteroviruses found in a variety of meningitides and found there was variation. They found echovirus 6 and 30 were the most common, but Coxsackie virus A9, B4, and B5 resulted in the higher viral loads and the more marked pleocytosis. So some enteroviruses are more virulent in people than others. And there was also a difference in the strains that cause diseases in adults and in children. So enteroviruses are different in their pathogenicity in human beings and in the groups that they infect. That's not of any practical significance given the testing we have, but interesting nonetheless. Although Ebola is currently having the big brouhaha. We often forget it's the mundane illnesses that kill people. It's estimated, for example, that rotavirus kills between 200 and 700,000 children under age 5 every year in the world, which is pretty jaw-dropping. And diarrhea still is the number 2 cause of death for children under age of 5. It's remarkable then what the rotavirus vaccine did in Ghana, where it decreased hospitalization due to diarrhea by 50%. A remarkable impact on mortality and hospitalizations in places like Ghana. The U.S., by comparison, has 20 to 60 deaths a year in kids under 5 due to rotavirus diarrhea. Not the same cause of mortality by any means. I refuse to say only 20 to 60 deaths in the United States, since when children die or anybody dies from an infection, it's never an only. You can always tell the anti-vaccine wackaloons because they always refer to the deaths of others as only. So a hodgepodge of flu-related articles. There was a study in China, Hong Kong specifically, where kids had received either the vaccine or placebo for flu. They followed these kids in the placebo wing for 3 years to see what happened to them. They got the flu. In the first H1N1 epidemic, 59% developed influenza, and then with subsequent epidemics of influenza sweeping through the community, they also got the flu. Depending on the strain that was circulating, they had different rates of influenza. The good news is that when they got influenza, they did get immunity to subsequent influenza due to the same strains of flu. But, of course, the price they paid for that immunity was being sicker than a dog. And if you have influenza as a kid, according to another recent study, if you present to the ER, the chance that you will have some important underlying problem, such as pneumonia, is 1 in 3. And those rates of an influenza-related complication go up if you have underlying medical problems. So if you're not vaccinated, you're likely to get the flu, and if you're sick enough to end up in the ER, you have a 1 in 3 chance of having a serious underlying complication from the flu. Flu bad. Wouldn't it be nice if we could prevent influenza with a vaccine? Oh, wait, we can. Children are a major source for the spread of influenza to populations outside of schools as well. But part of the problem is that kids under 2 years of age, like the elderly, do not respond well to the vaccine. However, if you could use a vaccine that had an adjuvant, perhaps you could get a better response. Adjuvants always give the anti-vaccine wackaloons the heebie-jeebies as well, but this study compared the standard vaccine to an adjuvanted vaccine in children 6 months to 10 years of age and found it to be superior in preventing influenza compared to the standard vaccine. So an adjuvanted vaccine would be of benefit with no increased risk of toxicities in the prevention of influenza in children. It is not uncommon when I ask a patient, especially a male patient, well, what brought you to the hospital? And in a surly voice, the male responds, "My wife made me," or "My girlfriend made me." This is confirmed in a recent study that looked at when and if people sought health care for influenza-like illnesses, and they often did not. And a variety of factors were associated with people with significant comorbidities not seeking health care for their influenza-like syndromes, being unemployed, big surprise, being uninsured, another big surprise, and being male, again, not a surprise. But it's interesting that the majority of people with underlying illnesses that flu could help kill them don't seek health care when they develop a flu-like illness. And finally, in the New England Journal of Medicine, they evaluated the high-dose flu vaccine in the elderly, found not only did it cause higher anti-influenza antibody levels, but it was more efficacious. They assumed that the 50% was the efficacy of the standard vaccine in adults, and that the high-dose had an estimated protection of 62%, which is about what you get in a young population. If you like rates, the rates of the high-dose vaccine for flu was 1.9% versus 1.4% in those who got the standard vaccine. So if you're 65 and older, the high-dose vaccine gives you a better antibody level and better protection. Plus, it has double the concentration of the new government tracking nanobots, so that the government will know where you are at all times. I'm sure there's at least one person out there that is sarcasm impaired. That last statement was sarcastic. I don't usually think about this, but it's probably worth noting in passing. There was a case report of hepatitis E in Germany being transmitted by transfusions. They do not test routinely for hepatitis E in the United States in the blood supply. So it's another unusual infection, along with West Nile and, I suppose, trypanosomiasis, given its ubiquity in some parts of the United States, that aren't routinely tested for in transfusions. Me, if I get a transfusion, I have them boil the blood first. Only way you can guarantee safety of the blood. I have wondered in passing how much of the C. diff we see in the hospital is acquired on the food. I also wonder if it may be going up as the hospitals in Portland are now moving to food on demand, and people order their food like a restaurant rather than having a plate of long overcooked food with all the listeria and C. difficile dead in it. This was an article that reviewed foodborne listeria in hospitals, and the source for these were sandwiches, butter, pre-cut celery, Camembert cheese, sausage, and tuna salad. It does sound like the new menus in my hospitals, so perhaps one of the things we might see a bump in as a consequence of more hotel-like hospitals is foodborne illnesses such as listeria, C. difficile, salmonella, etc. I have this theory, of course, that you die of your subspecialty, so I tend to get all my food deep fried since I should be immune from cardiovascular disease. I have mentioned innumerable times that infections lead to inflammation, which leads to vascular complications. But how about this study? Increased risk of dementia among chronic osteomyelitis patients. This is out of Taiwan, and they looked at a large database, and they looked at patients who had chronic osteomyelitis. And if you had a lot of comorbidities, your risk of dementia went up 5.48. If you got rid of all the comorbidities and you only had chronic osteomyelitis, you still had an increased risk of dementia at 1.73. So having chronic osteomyelitis in this population-based study was a risk for developing dementia, perhaps because of the ongoing inflammatory state. I'm intrigued by this. It is, of course, by no means definitive, but it is interesting that another inflammatory state, this time chronic osteomyelitis, may have an implication for the development of dementia. And please allow me to harp again. Infection leads to inflammation, leads to prothrombosis, leads to clot. How about, C. difficile? This study looked at the results of venous thromboembolism in a surgical cohort, and if you developed C. difficile, once you got rid of all the other problems, you still had an independent increased risk of venous thromboembolism with an odds ratio of 1.87. Yet another infection that leads to the formation of clot. I keep waiting for someone to write a masterful review of this topic for clinical infectious diseases. And I keep telling residents who are going to be fellows in the clot-based subspecialties, critical care, cardiology, that intervention studies will make your career if you could get started on it. It probably won't happen until I'm well into my syphilitic-induced dementia. Oh wait, am I oversharing? As I have mentioned before, no good deed in medicine ever goes unpunished. And every time you do something or not do something, you increase a risk of some sort. This study looked at the effects of PPIs on SBP. They looked at a summer of love population, 1965 patients, who had cirrhosis and ascites, and looked at the risk for SBP, and found that a small but significant risk for developing SBP if you were on a PPI. The hazard ratio was 1.396. If you look at the absolute numbers, it was 10.8% developed SBP if they were on a PPI, and 6% of those who were not on a PPI. These agents, as you may remember, also increase your risk for gastroenteritis such as C. diff and salmonella. Of course, doing things to people has benefits as well. The epidemiology of bacterial meningitis has changed somewhat in the United States, and there are two important features. First is that although strep pneumo continues to be the number one cause, there has been a significant decrease in both the incidence and the mortality of this organism. The decrease in the incidence has probably been due to the use of the conjugate vaccine in children. If you immunize the vector, you decreased the amount of infection in the host. And also, the use of adjunctive dexamethasone has probably been associated with decreased mortality due to this illness. So at least when it comes to pneumococcal meningitis, we've done good. I think we lose track of the benefits of infection control like hand hygiene and vaccinations because the result is things that don't happen. It's like the curious incident of the dog in the nighttime. The dog did nothing in the nighttime. That was the curious incident. Sometimes what doesn't happen turns out to be the important thing. And that's true of most of the public health and infection control procedures like vaccines. My wife keeps wanting me to lose a little weight. I could stand to drop about 20 pounds, I suppose. The problem is, as I mentioned earlier, is you die of your subspecialty. And obesity is linked to improved mortality in sepsis. So I'm more likely to survive my sepsis being a little chubby than I am if I were to get nice and thin. So I have to argue with her that I'm actually better to be a little on the large side. I think she'll probably buy that as much as she does my theory that my increased cholesterol just goes into testosterone synthesis and is a good thing. It doesn't go into the atherogenic pathways. I don't think she buys that either. She's not as gullible as I would like sometimes. So if you need some numbers for the efficacy of the BCG, and there was a recent meta-analysis in BMJ, here they are. This meta-analysis suggests that to prevent infection, it has a protective efficacy of 19%. But amongst those who are infected, it prevents progression of disease in about 58%, i.e. going from latent to active tuberculosis. So the BCG does prevent you from acquiring TB, but more importantly, if you acquire it, you're less likely to get disease from it. So in places of high endemicity, BCG is a worthwhile public health intervention. So what is the optimal therapy for tuberculous meningitis? I knew you were going to ask me that question. Well, this study out of China suggests that adding linezolid up front for the first month resulted in a much more rapid clinical and laboratory resolution of tuberculous meningitis. It was a retrospective study with all the problems therein, but still, if you have a severely ill patient with tuberculous meningitis, I've seen 2 in 33 years. Portland is not the hotbed of TB meningitis, but if it was, I would, after this trial, consider adding linezolid up front. Dengue is coming our way, thanks to mosquitoes. Now, the primary vector of dengue is the Aedes aegypti mosquito. And there are now breeding populations in California. I speak of the mosquito. There have always been breeding populations of Californians. And they look to see where this new mosquito has come from, which has been available in California since 2013. and it looks like it came from the southwest United States, not Arizona or Mexico, when they look at the bugs by their genetic thumbprints. Not that mosquitoes have thumbs, but you know what I mean. It's proboscis print. But looking at the DNA suggests that the mosquito that spreads dengue came to California from the American South. The nice thing about the Aedes aegypti is it feeds predominantly on humans. Also new in the United States is the Asian tiger mosquito, Aedes albopictus, and it too likes to feed predominantly on humans. And it turns out it's an excellent mosquito for spreading chikungunya, dengue, and La Crosse encephalitis. Other mosquitoes will also feed on other animals, which decreases the chance that they'll feed on you. But currently throughout the South and into California and up into Oregon are new strains of mosquitoes that have not been present in the United States and are very efficient carriers of these viruses. They keep predicting that we're going to have a chikungunya outbreak in the U.S. maybe this year, but more likely next year when it starts ripping through the human population. Parasites can give you the willies, or at least they give me the willies. And one of them is tungiasis, which is the sand flea disease. The parasites get in your skin and cause local inflammation. And in most of the world, you have to dig them out. And in most of the world, that's not a great thing to do, since mechanical extraction is not exactly done under the most aseptic of techniques. This study looked at the use of dimethicones of low velocity, a topical solution, on kids who had tungiasis, and found it was very effective at getting rid of the sand flea. So there is a topical treatment that would appear to be quite effective. A couple of months ago, there was a cool paper that suggested that narcolepsy from the influenza vaccine was due to cross-reacting antibodies to the vaccine to a protein that's involved with sleep, hypocretin. However, that was recently withdrawn because the researchers could not reproduce the study. Big bummer there, because it was an elegant explanation. And that ends this particular Puscast, a review of the infectious diseases literature. If you are interested, there are a pair of reviews out this month. One is in Clinical Infectious Diseases on maternal immunization, and then there's another one in PLOS Neglected Tropical Diseases on Arroyo fever and Verruga perunia, i.e. Bartonellosis. I usually don't talk about reviews, but I do like to mention they're out there if you're interested. They will be incorporated into the compendium. Otherwise, go to my website, edgydoc.com, for the references, which are also available on the podcast itself under lyrics. Otherwise, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you. In dictation. Goodbye.